23 Factitious Gastrointestinal Disease. John S. Fordtran, Anahit A. The alien and accepted principle of the patient-physician relationship is that the patient should make every attempt to regain health, including faithfully and unreservedly communicating to his or her physician the supposed cause of illness. 1-3 In at least 4 recognized disorders, patients typically or sometimes deviate from this covenant by self-inducing disease, feigning illness, withholding information regarding the cause of illness, exaggerating the severity of symptoms, or presenting a false medical history or medical records. These disorders include factitious disorder, FD, somatic symptom disorder, SSD, malingering, and eating disorders. The presumed motive for deviation from normal illness behavior varies in these 4 disorders, but regardless of motive, the result is that the physician is deceived. The purposes of this chapter are to discuss the possible etiologies of these abnormal illness behaviors, provide suggestions on how to recognize them, and point out some ethical conflicts that confront physicians taking care of such patients. We will emphasize the types of deceptive behaviors most likely to be encountered in the practice of gastroenterology and the iatrogenic diseases that are most likely to develop because of them. We will not discuss patients within these groups who present with psychiatric symptoms or with extreme manifestations of FD, such as Munchausen syndrome or Munchausen syndrome by proxy. Factitious disorder, subtle form. The subtle form of FD was first described in 1864 by Hector Gavin. 4 He observed it mainly in indulged females who 340 mimicked or counterfeited illness to gain compliance with their wishes, or to excite interest, or for the pleasure of deceiving. The motive for this behavior is believed to be relief of emotional distress by assumption of the sick role. These patients are usually women in their 30s. Typically they lead an outwardly normal life, are employed and medically insured, and are highly cooperative with their caregivers. FD is considered a psychiatric illness. 5 But the patients seek medical care from non-psychiatric physicians. Case 1 illustrates subtle FD, which is also referred to as the socially conformist type of FD. 6-8 Etiology and Motives. According to generally accepted teachings, patients with the subtle form of FD consciously and intentionally feign or self-induce physical symptoms to assume the sick role and thereby obtain relief from emotional distress. They present themselves with disabilities and disturbances that fall within the purview of physicians. 9 There are several possible explanations for FD behaviors, and one can draw on various theoretical frameworks. Learning theory suggests that excessive or deceptive illness behavior learned earlier in life is the best response the person knows. Psychodynamic theories draw on a number of possible conflicts, particularly in the child-parent relationship, resulting in the need to be cared for, the need to deceive, the need for revenge, the need to feel in control, the need for mastery over abusive parents, and the need to be punished or hurt. 10 By focusing on a physical illness, the patient can avoid the underlying painful feelings prompting these needs. The longing for nurturance and the need for distraction from authentic life problems. 11 Are also possible motivations. Behavioral theories point to exposure to and reinforcement of sick role activity. The self-enhancement model 10-12 suggests that individuals covet the specialness of their ailments and their relationships with high-status professionals, especially doctors. There is usually no apparent symbolic significance to the selection of the illness that is induced or feigned. 13 Patients with FD can simulate authentic disease in almost all organ systems, Table 23.1. Indeed, a given patient may use different manufactured symptoms and diseases at different times. It is generally believed that patients with FD are aware of what they are doing, as evidenced by careful planning in most cases. They know right from wrong. Their intelligent quotients, IQs, are usually normal or high, even if their educational attainment is relatively limited, and only very few are psychotic. Some are depressed and may have thoughts of suicide. As a group, they are sometimes described as being immature and lacking interpersonal skills. 14 Risk of iatrogenic disease. Patients with FD are usually willing and sometimes appear eager to accept dangerous diagnostic procedures in order to sustain the sick role. As a result of their deception, unneeded invasive and potentially dangerous diagnostic tests, procedures, and treatments are prescribed, and these may, in turn, result in iatrogenic disease. In most cases, the greatest damage to these patients is case 1. A 37-year-old woman with diarrhea. The patient began to have diarrhea a few days after undergoing reconstructive jaw surgery. Extensive evaluations failed to reveal a cause of diarrhea, and the patient was referred to our medical center, where she was evaluated as an outpatient. By quantitative stool collection, her average stool weight was 1008 g/day. Normal stool weight for women is 87 ± 8 g/day. The diarrhea was secretory in nature according to electrolyte analysis. Fecal fat output was within normal limits. Serum gastrin and vasoactive intestinal polypeptide, VIP, concentrations were normal, and stool culture revealed no pathogens. Because we were unable to find a cause of the patient's chronic secretory diarrhea, and because of multiple other medical and surgical illnesses prior to the onset of diarrhea, see later, we suspected surreptitious laxative ingestion with bisacodyl or senna. However, the patient denied ingestion of laxatives. A urine and stool laxative screen, ToxyLab, were negative, and the patient did not have pseudomelanosis coli on colonic biopsy specimens, see Chapter 128. We did not search her personal belongings, which were kept in her hotel room, and we did not confront her with our suspicion. She was discharged with advice on fluid and electrolyte replacement and symptom management, and with an offer to return at any time. Approximately 1 year after her evaluation at Baylor University Medical Center, the patient went to another medical center, where endoscopies were repeated, but no diagnosis was forthcoming. A colonoscopy with biopsy was complicated by severe bleeding, and she required transfusion of multiple units of blood. Owing to continuing weight loss, parenteral nutrition was begun. After the diarrhea had been present for about 4 years, she returned to Baylor University Medical Center. By that time, we had shown that the ToxyLab assay for laxatives was unreliable. We therefore had her urine analyzed by thin-layer chromatography, and it tested positive for bisacodyl. We decided to confront the patient in a supportive manner, see later, and did so in the presence of her husband, who was with her continuously during her outpatient evaluation. With a few tears, she calmly said that she had absolutely not been taking laxatives and added, "I don't know what bisacodyl is." After discharge, her husband searched her closet at home and found an empty box of Correctol for women, which contains bisacodyl. The husband and her local physician agreed to obtain psychiatric help for the patient. Later, we spoke with members of the patient's family to try to gain insight into her motivation for surreptitious laxative ingestion. According to her family, there was no evidence of an eating disorder or sexual abuse. For the previous 6 years, she had worked in a doctor's office, where her knowledge of medicine had increased. She's always been a great believer in medicine, and she doesn't see the risks. She had undergone multiple orthopedic surgeries without any clear need, and the jaw surgery was done for a questionable indication. These surgeries made her the center of attention. She was married to a loving and caring husband. The diarrheal illness started about 3 months after her diagnosis of infertility. Others have observed that the onset of FD often begins shortly after a stressful event. 0.6,7 About 3 years after the diagnosis of FD, the patient's family and some of her local physicians were contacted again for an update. Generally, things were much better. Although the decision to confront the patient was probably wise, the patient had felt betrayed. She never accepted the diagnosis and refused to see a psychiatrist. She still had various medical problems with frequent appointments with specialists. She remained fascinated with illness but was less dramatic and received less attention because of it. 2 weeks before these conversations, the patient had had hip surgery, and several months before she had had a cholecystectomy. Earlier in the year she had had surgery to correct damage caused by teeth grinding. She's probably not taking laxatives anymore, but several times a year her potassium level is low, and on one occasion a diuretic was found in her urine. Based on this information, it seems clear that her fascination with medicine and her polysurgical addiction continue. Table 23.1 Manifestations of factitious diseases by mechanism * Mechanism manifestations: self-induced infection, abscesses, bacteremia, fever, sepsis, wound infection, surreptitious ingestion of medicines, vitamins, minerals, Bartter syndrome, bleeding or purpura from coagulation disorder, decameral, heparin, bone marrow depression, diarrhea, hyperthyroidism, hypoglycemia, hypokalemia, laxatives and/or diuretics, hypomagnesemia, liver disease, pheochromocytoma, epinephrine injection, renal failure, salt poisoning, vomiting, self-induced injury, bruises, complex regional pain syndrome, reflex sympathetic dystrophy, deformities, dermatosis, may also be induced by ingestion of certain drugs, unhealed wounds, phlebotomy, self or animal, anemia, hematemesis, hematochezia, hematuria, melena, thermometer manipulation or substitution of thermometer, fever, simulation of the clinical manifestations of specific AIDS, cancer, CF, depression, multiple sclerosis, pain syndromes, pancreatitis, proteinuria, diseases or syndromes, sometimes using falsified seizures, psychosis, renal stones, medical records or contamination of body fluids. Organization was modified from reference point 14 due to doctor's actions, rather than from any direct action by the patient. 15 FD patients presenting with GI symptoms or signs may receive needless laparotomies, gastric or intestinal resections, pancreatectomy, renal biopsy, adrenalectomy, or prolonged treatment with glucocorticoids. Case 2 illustrates some of these points. Diagnosis and detection: early recognition of patients with FD is the best way to prevent iatrogenic disease, but most internists and gastroenterologists never consider FD in the differential diagnosis of patients with idiopathic physical symptoms. A factitious etiology of physical symptoms simply does not make sense in a traditional medical context. Therefore, negative test results for authentic diseases are considered false negative results. The tests are repeated, new doctors are consulted, tests with low specificity for extremely rare authentic diseases may be performed, and false positive results lead to more tests. Even if FD is considered in the differential diagnosis, several factors make it difficult for physicians to recognize the subtle form of FD. First, these patients do not appear to be different from other patients with similar symptoms caused by authentic disease. 16-17 Case 2 Iatrogenic disease in a 33-year-old woman. The patient felt well until 8 years earlier when she developed constipation requiring laxatives. Later that year she developed diarrhea. Colonoscopy revealed mild colitis, and X-rays suggested ileitis. Over the next 2 years, the diarrhea persisted despite many different diets and medications, including prednisone. Salt depletion occurred frequently, requiring multiple hospitalizations. The patient developed a septic necrosis of both hips, presumably the result of prednisone therapy, and had a total left hip replacement. Severe diarrhea continued, and she underwent several surgical procedures: exploratory laparotomy, loop ileostomy without bowel resection, and subsequently a total colectomy with standard ileostomy. The pathology report showed nonspecific chronic inflammation. Postoperatively, the patient had severe ileostomy diarrhea. A neuroendocrine tumor syndrome was suspected, and she was referred for further studies. A balance study revealed that the ileostomy volume was 2,561 ml/day, normal 600, the diarrhea was secretory in type, and intestinal absorption of dietary fat was normal. Intestinal perfusion studies showed normal small bowel absorption of water and electrolytes. The patient denied use of laxatives since the onset of her diarrhea. However, her room was secretly searched, and a box of Carter's Little pills was discovered, which contained several anthraquinones including podophyllum and aloin. See Chapter 19. A review of her medical records near the time of her colectomy revealed a pathology report on a rectal biopsy specimen that described pseudomelanosis coli. Box 231 clues that increase the likelihood of subtle forms of factitious disorder, predominantly women. Previous experience in the medical field: which provides an unusual grasp of terminology and access to medical supplies, multiple surgeries, multiple procedures, inexplicable laboratory test results, inconsistency and implausibility of certain aspects of the history, visits to 3 or more medical centers previously for the same symptoms or to a nationally known referral center, despite residing far away, history of substance abuse or prior psychiatric disorder, vagueness about details of past history and/or reluctance to allow release of previous medical records. Second, the psychiatric illnesses they have are not easily recognized. 18 And there is usually no obvious excessive secondary gain that these patients are receiving. Third, the patients convincingly deny self-induced illness if they are asked. 17,19 Fourth, there is a lack of communication between current and previous doctors, as well as a failure to study old medical records. Fifth, physicians are afraid to discuss the possibility of FD with their patients. Several clues, if present, increase the likelihood of FD in a particular patient. Box 23.1, however, the diagnosis of FD cannot be made solely on the basis of clues, so some form of confirmation must be obtained. Box 23.2 provides a list of some of the methods that have been used to bolster or confirm a suspicion of self-induced illness. If the attending physician considers FD and obtains a psychiatric consultation, it is important to recognize that even an experienced psychiatrist cannot reliably make or rule out a diagnosis of FD by taking a psychiatric history from a patient who is suspected of having FD but denies it. Box 232 Methods that have been used to bolster or confirm a suspicion of self-induced or factitious disorder. Review old medical records and discuss the case with previous doctors and family members, if appropriate. Identify discrepancies and inconsistencies and estimate the influence of gain derived from the sick role. Inquire about psychosomatic illness, previous psychiatric treatment, suicide attempts, stress in the patient's life, childhood abuse, marital/sexual problems, eating disorders, etc. The Internet can be used to facilitate such a review. A forensic consultant with access to multiple records can be uniquely helpful in identifying conflicting stories. Review previous biopsy slides to look for foreign body material in wounds. 22 Pseudomelanosis coli 23 and other clues, as appropriate for the patient's symptoms. Obtain a psychiatric evaluation to help determine whether the patient has a personality disorder or psychiatric disease, absence of which would argue against factitious disease. If symptoms and signs may be explained by surreptitious ingestion of medications and poisons, obtain appropriate medication and toxicology screens. Consider obtaining a urine test for diuretics even in the absence of renal or electrolyte abnormalities. Evaluate the results of such screens in light of the sensitivity and specificity of the tests used. Test biological fluids collected under direct observation and compare the results with those for fluids collected privately by the patient. For example, compare fecal material obtained at an unprepped sigmoidoscopy with fecal material submitted by the patient. Have a member of the nursing staff observe the patient to detect tampering behavior. Search the patient's personal belongings. See text. Management. 2 main assumptions form the basis for the proposed management recommendations. The first is that FD represents the patient's attempt to cope with emotional distress. The second is that a supportive attitude by the healthcare team will make it possible for the patient to live through the shame and shattered self-image that may result from a diagnosis of FD. Unfortunately, almost all management recommendations that have been reported were based on experience with patients who were hospitalized. We know of no suggested recommendations for outpatients. Techniques that have been used for the management of FD include confrontation of the patient, psychotherapy, drug treatment, behavioral therapy, and multidisciplinary approaches. Eastwood and Bisson 24 attempted to evaluate the effectiveness of these management methods by reviewing 32 case reports and 13 case series. Based on their review, these authors concluded that the evidence in the literature is insufficient to evaluate the effectiveness of any management technique. Nevertheless, there appears to be a general consensus in the literature on several aspects of the treatment of FD, as listed in Box 23.3. Although these recommendations are probably accepted by most experts, differences of opinion exist on the value and wisdom of confronting a patient with a diagnosis of FD. Combining the recommendations from the authors of 3 studies 14,25,26, there seems to be a consensus that confrontation of patients with confirmed FD should be done when there is a danger of significant iatrogenic disease. All agree that the confrontation should be supportive, as enumerated in box 23.4. There is no consensus on whether confrontation should be done when FD is suspected but unproved or when the danger of iatrogenic disease is judged to be small. Box 233 Consensus opinions on the treatment of factitious disorder *. Achievement of insight should not be the principal early goal of treatment, because it can weaken the patient's defenses. One person should have primary responsibility for patient management. There should be a comprehensive psychiatric evaluation of the patient, including assessment for suicide risk. All members of a multidisciplinary team should be aware of the assessment and treatment plan. The treatment plan should be individualized. Comorbid illness should be treated appropriately. If confrontational techniques are used, they should be non-punitive and supportive. Derived from the literature. Box 234 Features of supportive confrontation. Tell the patient what you suspect without outright accusation. Support the diagnosis of factitious disease with facts. Provide empathetic and face-saving comments. Avoid probing to uncover the patient's underlying feelings and motivations. Assure the patient that the physician will not release the diagnosis to others without the patient's permission, unless required to do so by law. Make sure the staff demonstrate continued acceptance of the patient. Encourage psychiatric help, but do not force the issue. Maybe you didn't know what you were taking. This medication could cause you to be sick. Maybe you took it in your sleep. What you did was a cry for help, and we understand. We realize you must be in great distress. We want to continue to take care of you. This is done to minimize disruption of essential emotional defenses. Later it may be decided to break this promise in patients with potentially fatal factitious disease, such as patients who are creating sepsis by injecting contaminated material into their bodies. This promise should only be broken after consultation and consensus opinion has been obtained by an ethics committee, legal personnel, and others, as described in the text. Management without confrontation is sometimes referred to as a face-saving technique. 27,28 Here the patient is gently given the message that the doctors are wise to the deception and that he or she is being offered a chance to abandon factitious disease before it is exposed. The patient may be told that if the next treatment fails to work, we are going to be forced to conclude that you are the source of your own illness. The next treatment, almost any treatment, is then applied, and a surprising number of patients will undergo miraculous improvement rather than risk being exposed as a fraud. One report concluded that after such non-confrontational approaches, about 1/3 of the patients ended their hoaxes. They may have vigorously denied what they were doing, but if the doctors somehow allowed them to save face, the behavior stopped for some time. Therefore, the embarrassment of discovery is avoided in a substantial minority of patients. Even if patients admit to some or all the deceptions, however, most will continue to induce or feign disease. This trade-off is acceptable, provided the danger of iatrogenic disease is judged to be small, with the recognition that no therapeutic technique is consistently effective. 27 Although this face-saving technique is favored by several experts, the authors are not aware of results of this method in a case series of patients with the subtle form of FD. In general, treatment of FD seldom leads to cure. Some patients temporarily discontinue their illness-seeking behavior, but most are unwilling to accept psychiatric referral and probably will continue to self-induce or feign disease. Whenever possible, a psychiatrist should assess the patient for comorbid psychiatric disorders, e.g., major depression or personality disorders, that may predispose the patient toward, or contribute to expressions of, factitious illness behavior. If underlying psychiatric disorder can be recognized and treated, the psychological forces driving the FD may be lessened. The patient should also be assessed for suicidality and, when appropriate, should be transferred to a more secure setting. Psychiatric hospitalization is indicated when a patient has suicidal ideation or attempts suicide, has a deteriorating social situation, or manifests severe acting out. 25,29 When recovery occurs, it most often results from changes in the patient's life situation rather than from medical intervention. 30 Ethical issues related to privacy and confidentiality in some patients with FD. A secret search of a patient's personal belongings can be life-saving. 14 It may also prevent devastating iatrogenic disease. 31 Moreover, patients may deny self-injury, but when they are confronted with evidence obtained from a room search, they often stop this practice. For two reasons it is difficult to secretly search a patient's private possessions in the hospital, even when suspected self-induced disease is likely to be fatal. First, there are ethical and legal objections to a secret search of a patient's personal possessions. 32 Second, some general hospitals have essentially promised that a secret search will not be done. This is not the case for most psychiatric hospitals. This promise is given to each patient admitted to our hospital. 33-34 Keeping the promise is not a major problem if there is minimal or only modest risk to the patient of serious self-induced or iatrogenic disease. But what should be done with a patient suspected of life-threatening FD or when the risk of serious iatrogenic disease is deemed to be high? One possibility is for the doctor to tell the patient of his or her suspicions and ask for informed consent to perform a search of the patient's personal possessions. This approach would require planning, including preparation of a specific informed consent document. The patient would be told that the search is necessary before further invasive diagnostic tests are done. If the patient agrees to the search, and if it reveals evidence of FD, the suspicion would be confirmed. If the patient does not allow a search, the referring doctor, and possibly the patient's family, could be advised about the likely implications in the hope that this knowledge would reduce the likelihood of future harmful effects of suspected self-induced disease. If the search is negative, or if the patient refuses to allow the search, the physician may feel compelled to withdraw from the case, provided that another doctor can be found who will assume responsibility for the patient. Treating a search of a patient's belongings just like any other medical procedure sounds simple enough and has been recommended. 32 But we know of no reports describing the results and effects of asking patients for consent to search their personal belongings. Some patients with FD forbid physicians from telling their families about a diagnosis of FD. This can create a dilemma because under the Health Insurance Portability and Accountability Act, physicians can be sanctioned for violating confidentiality, as illustrated by a case reported by Dr. Charles Ford, M.D. Feldman, Personal Communication, 2000. A medical student's wife cleverly simulated good pasture syndrome. Faced with the need to provide care for her, the medical student was in danger of failing his classes. The wife threatened the consultant, who had made the correct diagnosis, with a lawsuit if he violated confidentiality and communicated the true nature of her disorder to either her husband or her primary care doctor. The best approach to such dilemmas is to consult with risk management and other physicians, such as the hospital's chief medical officer, and with the ethical and legal committees of the institution. The issues are best discussed thoroughly in a team setting so that a consensus can be reached. Legal issues: physicians may assume that they will never be subjected to a malpractice suit from a patient with FD. After all, the patient has fabricated his or her own illness and did not provide a truthful medical history. Nevertheless, the number of plaintiffs with probable factitious illness who are pursuing lawsuits has been increasing. 35 Such suits may be prompted by the patient's rage or represent an effort to change the center of attention from the hospital to the courtroom. 36 Similarly, failure by a physician to recognize FD can serve as the basis for litigation. In one such case, a former medical student sued 35 physicians collectively for negligence, because they treated her with chemotherapy for a cancer she did not have. The case was settled out of court. 37 Another example involved amputation of a leg in a patient feigning reflex sympathetic dystrophy. One of the arguments plaintiffs have used against their doctors is that strong evidence of the factitious etiology of their disease was present in the medical records, but the doctor did not read those records. It has therefore been concluded that factitious disease is not a reliable defense against a bad outcome. 38 And that fraudulent conduct by a patient does not dissolve the legal and ethical aspects of the patient-physician relationship. 39 At the same time, it must be recognized that uncovering deceptive behavior does not negate the risk of authentic disease or injury. For example, intentional exaggeration of symptoms may reflect a desperate attempt at attention for a medical problem the patient actually has. 10 We found no lawsuits related to invasion of privacy, breach of confidentiality, or failure to obtain informed consent. Obviously, any violation of confidentiality should be in the interest of protecting the patient's health or significantly reducing the damage to others. 40 Careful and complete contemporaneous documentation in controversial cases will afford some protection. Second opinions supporting the actions taken will also reduce the likelihood that a lawsuit will be launched or prove successful. Related abnormal illness behaviors. Somatic symptom disorder (SSD) can be defined as idiopathic physical symptoms that begin before age 30, that over time are located in different parts of the body, and that cause disproportionately severe disability and impaired function. The main symptom is pain. There is no evidence that pain in patients with SSD is intentionally feigned or exaggerated, but there is no way to prove that it is not. See also chapters 12 and 22. The onset of physical symptoms often closely follows a traumatic event, and the physical symptoms may coexist with other psychiatric disorders such as depression. A large majority of patients are female. The patients seek medical care for their symptoms, but no authentic medical explanation can be found. Secondary gain from assumption of the sick role is often apparent. In some patients, symptoms and illness become a means of communication. 41 And a way of controlling their environment. Case 3 A 20-year-old woman with abdominal pain. A college student developed left-sided periumbilical pain associated with nausea. She was so disabled by the pain that she had to drop out of school. She was placed on opioids, but the pain persisted. CT showed a jejunal intussusception. The patient was scheduled for abdominal surgery, but her family decided to obtain a second opinion. At our center she described her pain as constant, aching, and burning, 10 of 10 in severity, and located in the left mid-abdomen. The pain was not related to meals, bowel movements, or her menstrual cycle. She did not have constipation or diarrhea. Her past medical history revealed an inguinal hernia, right knee arthroscopies, chronic back pain, chronic pelvic pain, depression, fatigue, and a menstrual disorder. During physical examination she was passive, appeared depressed, and did not appear to be in severe pain. There was minimal tenderness to palpation. Review of CT images with a radiologist confirmed intermittent jejunal intussusception without obstruction. Because it is known that most small bowel intussusceptions discovered incidentally by CT scans are asymptomatic, transient, and do not warrant surgical management. 43 We doubted that the jejunal intussusception was the cause of her abdominal pain. Endoscopy to the mid-ileum revealed no abnormalities. A surgical consultant agreed that the patient's pain was not caused by the jejunal intussusception seen on CT scan. The gastroenterologist and the surgeon made a diagnosis of SSD. The patient was referred to a psychiatrist to evaluate her for depression and suicidal risk. Several years later, her condition was more or less unchanged. She still had pain, but it was located in the chest rather than the abdomen. She had not returned to school or been employed, and she appeared to be highly dysfunctional. However, under pleasant circumstances, as at a party, she sometimes appeared to be happy and physically active. The dysfunction and disability attributed to the symptoms often appear to be out of proportion to the severity of the symptoms. The course of SSD is usually chronic. Once established at a young age, it can continue into advanced age. 42 An example of SSD is presented in Case 3. The underlying etiology of SSD is unknown, but several mechanisms have been proposed. They include the hypothesis that patients with SSD experience psychologic distress in the form of physical symptoms. 44 Another theory is that the patient learns the behavior that manifests his or her belief in the supposed affliction and that the resulting illness helps the patient to cope. 45 The boundaries of SSD are obviously not sharp, merging imperceptibly with illness anxiety disorder on one side and with FD on the other side. 45 Diagnosis of SSD depends on recognizing two features of the patient's illness. First, there has been illness-seeking behavior for multiple idiopathic symptoms related to different organ systems, and second, the disability and dysfunction attributed to the symptoms are disproportionately high. In one report, patients with SSD spent 7 days in bed each month, compared with 0.48 days for a general population. 46 Patients with SSD are not as fascinated by doctors as patients with FD. Unfortunately, even highly skilled physicians repeatedly fail to recognize SSD42 and they, therefore, obtain diagnostic tests for rare and then very rare conditions. These patients are highly vulnerable to such practice because repeated diagnostic tests often reveal questionable abnormalities that can lead to complications from medical treatments, e.g., glucocorticoids or narcotics, invasive procedures, or surgeries. For the management of patients with the SSD, a caring rather than curing approach is recommended. 47 An empathetic, long-term relationship should be established, preferably by one physician. Regular appointments should be scheduled, and brief physical examinations are preferred over extensive diagnostic tests and procedures. 48 Prescribed medication should be kept to a minimum, and opioids should be avoided. 47 Because depression is common, these patients should be evaluated for suicide risk. 5 Confrontation should be avoided because motivation in SSD is supposedly unconscious, but some awareness of emotional components can be achieved. 47 In a randomized controlled clinical trial, it was found that cognitive behavioral therapy was associated with significant improvement in self-reported functioning and somatic symptoms and decreased healthcare costs. 49 These improvements, however, could have been due to the increased attention and extra time that was invested in the experimental cognitive behavioral therapy treatment. 47 Malingering As with the subtle form of FD, Gavin was the first to describe malingering. 4 Malingering is defined as conscious and intentional production or exaggeration of symptoms and signs of disease for material gain, such as money, lodging, food, narcotics, avoidance of military duty, and escape from criminal prosecution. Malingering is not always a reflection of greed. It might instead be the result of financial desperation or an attempt to escape physical or emotional abuse. 51 Of our patients with surreptitious laxative ingestion stated that she induced her illness in order to keep her husband from leaving her. A careful medical and social history is obviously required to put this medical deception into proper context. 50 As with FD, malingerers seek medical care for the symptoms and signs they feign or produce, and they hide the true etiology of their symptoms from their physicians. Malingerers typically are not as willing as patients with FD to accept dangerous diagnostic or therapeutic procedures, and they may attempt to minimize contact with healthcare professionals in order to avoid detection. 50 The distinction between malingering and FD is based on the perception of motive, material gain for malingering and emotional gain from the sick role for FD. Perception of motive, however, is not always correct and is subject to bias. 50 Clinicians should also be aware that an individual's goals, whether internal or external, conscious or unconscious, can vary over time or coexist. 51 Moreover, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition 5 recognizes that motives can merge in individual cases and allows simultaneous diagnosis of FD and malingering. Unlike FD and SSD, malingering is not considered to be a mental disorder. Factitious behavior in patients with bulimia. Patients with eating disorders often develop GI symptoms, many of which are caused by laxative abuse or self-induced vomiting. See Chapter 9. 52 When they seek medical care for these symptoms, they often do not inform their doctors about their eating disorder or their purging activity. The motives for such abnormal illness behavior were explored in a videotaped interview 33 conducted by Dr. Michael Carmichael, an internal medicine resident. Parts of that interview are as follows. Patient: when I first went into the hospital and had tests run, they found nothing at all. Doctor: okay. Were you taking any medicines at that time? Patient: no medicines, no. Doctor: were you taking laxatives at that time? Patient: yes. Doctor: okay. What happened after that, after you left the hospital? Patient: I was better for a while and then I got worse a few months later and went into another hospital and had the same tests done again. The only thing they found was that I had gastritis. Doctor: and yet, the doctors in these hospitals did quite a few tests on you, and even some tests that I'm sure were painful and expensive and a lot of trouble for you. Did you think about that? I'm curious about what you thought about all of that. Patient: I really thought, tried to tell myself, that there must be something else wrong. Doctor: did the doctors ever ask you at that time about laxatives and if you were taking them? Patient: no. Doctor: if the doctors had told you that you needed an operation, say, to find out what was wrong with you, what do you think your reaction would have been to that? Patient: I believe I would have gone along with whatever they said. Doctor: why? Patient: I really don't know. Doctor: can you tell us a little more about taking the laxatives and specifically why you picked laxatives as opposed to something else? Patient: I felt that I could eat anything I wanted to and for the first time not have to worry about what I ate and still not gain any weight. Doctor: so it was to keep your weight down. Patient: right. Doctor: okay. You were taking Correctol, I think. Isn't that correct? Patient: yes. Doctor: how many did you take, would you say, in a day's time on average? Patient: at the worst time, I guess about 40 a day. Doctor: 40 tablets a day. That's a lot of tablets. Patient: yes. Doctor: how did you feel when we told you that we thought the problem with the weight loss was because you were taking laxatives? What did you think when we brought this up? Patient: I was so relieved. I've never felt that relieved in my life. I wanted somebody to know, but I couldn't bring myself to tell anyone. Untapped interviews with other patients revealed qualitatively similar motivations, except that some recognized the cause of their GI symptoms and sought medical care only because their families insisted on doing so. None showed evidence of seeking a sick role for relief of emotional distress. All experienced shame for their purging behavior and for concealing it from their doctors. 2 of these patients had undergone abdominal surgery for their GI symptoms. To evaluate the degree to which laxatives reduce caloric absorption after binge eating, normal subjects and 2 patients with bulimia were studied in a metabolic research laboratory. The results revealed that laxatives had a relatively small effect on calorie absorption. 53 For example, after ingesting food containing 1,726 kilocalories followed by 50 Correctol tablets, one of the patients had 6.1 L of diarrheal fluid weighing 13.6 pounds. This high-volume diarrhea decreased caloric absorption by only 188 kilocalories, compared with a control test day when the patient ingested similar foods without Correctol. Special issues related to gastroenterology. Surreptitious laxative ingestion. Diarrhea caused by surreptitious ingestion of laxatives is often associated with abdominal pain, weight loss, electrolyte derangements, and / or postural hypotension. Depending on which of these manifestations are revealed to the physician and which are hidden, the clinical presentation can be highly variable. Diarrhea in association with hypokalemia, abdominal pain, weight loss, or postural hypotension have different well-known connotations that provoke specific diagnostic studies. If the existence of diarrhea is hidden, the patient may appear to have an exotic disease that creates excitement among nephrologists and endocrinologists. 54,55 In any case, the usual tools of gastroenterology will not reveal the correct diagnosis and will often be misleading. Only gastroenterologists who know the information in boxes 23.1 and 23.2 will be likely to make the correct diagnosis. Factitious diarrhea. When gastroenterologists refer patients with chronic idiopathic diarrhea to a medical center that has a special interest in diarrheal disease, the most common specific diagnosis that can be made is ingestion of laxatives, see Chapter 16.56. To a significant degree, diagnosis of laxative ingestion in patients who deny laxative intake depends on the ability to detect laxatives or their metabolic products in stool or urine by analytical methods. It is important to recognize, however, that any mistakes in the determination of laxative intake could have serious deleterious consequences. False negative results delay the diagnosis of factitious disease for years and contribute to complications from unnecessary or inappropriate medical or surgical therapy. Conversely, False positive results prematurely stop the diagnostic evaluation for an authentic disease and may result in a patient's being incorrectly accused of self-induction of disease, which could cause severe psychological harm. Bisacodyl and senna are the most common laxatives ingested surreptitiously to produce factitious diarrhea. 57 Research laboratories have reported 100% sensitivity and specificity for identification of these drugs by thin layer chromatography, TLC, of urine, and it has been recommended that patients with idiopathic diarrhea be routinely tested for ingestion of these laxatives before invasive or costly diagnostic and therapeutic procedures are performed. 17,18 Before 2007, a reference laboratory in the USA offered TLC analysis on urine and stool to detect ingestion of these drugs. To evaluate the accuracy of the procedure, we induced diarrhea in healthy volunteers by having them ingest bisacodyl, senna, or control laxatives. Samples of urine and diarrheal stool were sent in blinded fashion to the clinical reference laboratory for bisacodyl and senna analysis. The results showed that this laboratory's TLC assay for senna had a sensitivity of 0%, in other words, all subjects with diarrhea due to senna had false negative results. The company's assay for bisacodyl yielded false negative results in 18% and false positive tests in 7% of submitted urine and stool samples. The calculated predictive value of a positive test for bisacodyl in urine as a function of the prevalence of bisacodyl-induced diarrhea in various populations is shown in Fig 23.1. The reported frequency of bisacodyl-induced diarrhea among patients with cryptogenic diarrhea under the care of a general practitioner is about 2.4%. 57 At this frequency, the vast majority of positive urine tests for bisacodyl would show false positive results. Aside from analytical mistakes in the testing procedure, part of the problem with TLC may be that the results are reported as none detected or positive, rather than quantitatively in terms of weight per liter or weight per day. Theoretically, minuscule quantities of contamination, too small to induce diarrhea, from ingested substances or from endogenous metabolism might produce false positive results. This same reference laboratory currently offers tests on urine, but not on stool, for bisacodyl and anthraquinones by high-performance liquid chromatography/tandem mass spectroscopy. These results are also reported on a positive or none-detected basis without quantification, and we are aware of no studies on the sensitivity and specificity of these procedures when samples of urine from normal research subjects ingesting different laxatives are submitted for blind testing. Based on all information available to us in 2019, we believe that these tests should not be ordered unless there is judged to be a high likelihood of factitious disease. See boxes 23.1 and 23.2, and unless stool analysis has revealed secretory diarrhea. Any positive result obtained on a patient with osmotic diarrhea would almost surely be falsely positive because bisacodyl and senna do not cause osmotic diarrhea. This situation would change if a commercial laboratory would prove that their tests for bisacodyl and anthraquinones in urine are highly specific and sensitive in people with diarrhea. In patients with chronic idiopathic diarrhea, analysis of fecal fluid for monovalent electrolytes, Na, K, and Cl, pH, and osmolality can identify the presence of osmotic or secretory diarrhea. See Chapter 16. When osmotic diarrhea is induced by ingestion of poorly absorbed solutes such as magnesium, sulfate, phosphate, or polyethylene glycol, chemical methods can quantitatively determine their percent content in fecal fluid. 58 The effects of these osmotic laxatives have been studied in normal subjects, and the fecal fluid concentrations from normal people and from normal people with laxative-induced diarrhea have been established for each solute. When this method of testing was evaluated in 158 patients with chronic idiopathic diarrhea, 8%, 12 of 158, were found to have diarrheogenic concentrations of one of these osmotic laxative in their fecal fluids. 58. Lactulose also causes osmotic diarrhea, but by fecal analysis it would be indistinguishable from legitimate causes of carbohydrate malabsorption. These results indicate that early use of simple chemical tests in patients with idiopathic chronic osmotic diarrhea would markedly reduce utilization of expensive and sometimes dangerous diagnostic procedures that have no ability to detect laxative ingestion. Finding a true positive test for laxative ingestion in a patient with idiopathic chronic diarrhea is not conclusive evidence for surreptitious laxative ingestion or factitious diarrhea, because frequency, %. Fig 23.1 correlation between the likelihood that a positive urine test for bisicodyl by thin layer chromatography is a true positive or a false positive result and the frequency of bisicodyl-induced diarrhea in tested populations. The patient may have been unknowingly ingesting the laxative in a medication, magnesium in an antacid, for example, or in a health supplement, which may contain anthraquinones. Innocent explanations such as these need to be carefully considered when a positive test for laxative intake is obtained. 59 Unknown laxative ingestion is among the most satisfying diagnoses that a physician is likely to make in patients with chronic idiopathic diarrhea because stopping inadvertent laxative intake can cure chronic diarrhea. Diarrhea can be feigned by diluting stool with water. This dilution can be carried out in vitro after a stool specimen is collected or in vivo by giving oneself a tap water enema and then collecting the rectal effluent. This type of factitious diarrhea can be identified by measuring osmolality of the fecal fluid supernatant and finding values far below the average physiological level of 290 mosm/kg. In a patient seen at our institution, fecal fluid from a submitted 48-hour stool collection had an osmolality of 83 mosm/kg. This dilutional form of factitious diarrhea would not be detectable by measurement of fecal fluid osmolality if stools were diluted with normal saline. As discussed in Chapter 128, pseudomelanosis coli develops in more than 70% of patients who use anthraquinones laxatives, e.g., cascara, aloe, senna, etc., on average within 9 months of regular intake of these products. The effect is said to be reversible within 1 year of discontinuing the intake of an anthraquinone. Finding this pigment, lipofuscin, at colonoscopy or in biopsy specimens is suggestive, but not diagnostic, of recent anthraquinone ingestion. Other apparent causes for this condition include ingestion of an NSAIDs.60 concealed vomiting in the early part of the 20th century. Gastroenterologists and surgeons recognized that persistent vomiting due to gastric outlet obstruction could lead to severe toxemia, with volume depletion, hypochloremic metabolic alkalosis, hypokalemia, uremia, and tetany. 61 Based on subsequent clinical research, it was discovered that the pathogenesis of vomiting-induced electrolyte abnormalities is as follows: vomiting, loss of HCl and volume contraction, metabolic alkalosis, increased renal excretion of bicarbonate, increased renal excretion of potassium and sodium, hypokalemia, and more volume contraction. The alkalosis also causes potassium to move from extracellular fluid into the intracellular spaces, further reducing the serum potassium concentration. In the 1960s, hypokalemia and hypochloremic alkalosis due to primary renal potassium wasting, Bartter syndrome, were reported. 62 Soon thereafter, it was shown that concealed vomiting or surreptitious thiazide ingestion could mimic almost all features of Bartter syndrome, including high plasma concentrations of renin and aldosterone and hyperplasia of the juxtaglomerular apparatus. 63-66 Suddenly, the metabolic effects of surreptitious vomiting were exciting topics at medical grand rounds, and this reawakened interest in other causes of chronic vomiting. When patients surreptitiously self-induce vomiting and then present to physicians seeking a cause for their vomiting, identifying the factitious nature of the vomiting can be difficult. When patients conceal episodes of induced vomiting and present with hypochloremic alkalosis and hypokalemia, they will be subjected to diagnostic studies that suggest Bartter syndrome or other rare diseases with similar features. A useful clue to concealed vomiting as the cause of hypokalemia and alkalosis is an extremely low rate of urine chloride excretion, even when a patient is ingesting a diet containing a normal amount of chloride. This is not present in Bartter syndrome or surreptitious thiazide ingestion. 63 The interesting history of syrup of ipecac has been reviewed. 67 In 1965, the FDA granted over-the-counter status for this compound as an emetic. This designation was rescinded in 2003,68 because of lack of clinical benefit in poisoned children, adverse events, and abuse by bulimic patients. 69 Factitious anemia and factitious GI blood loss. Factitious anemia should be considered when there are repeated instances of unexplained sharp drops in the hemoglobin concentration, with appropriate but unsustainable responses to blood transfusions. 70 Patients with FD usually use phlebotomy and/or placed 4 lines for self-bloodletting to create factitious anemia. They may also ingest collected blood by mouth to mimic hematemesis and melena, or add the blood to urine or stool samples to create hematuria and hematochezia, respectively. A patient was described who lacerated her distal colon with long knitting needles, thereby resulting in bloody diarrhea. 71 A patient with cirrhosis and acute upper and lower GI bleeding underwent colonoscopy, which revealed linear ulcers in the rectum, and 2 straight-edge razor blades were found in the cecum. 72 One report 73 discussed a 23-year-old patient who had repeated admissions to the hospital for GI bleeding. Multiple endoscopic studies revealed no authentic bleeding site. Several therapeutic procedures were performed, including embolization of gastric blood vessels. Later, her physicians noted behavioral features of FD, including lack of concern over her long hospital admissions and her willingness to tolerate multiple endoscopic procedures with minimal sedation. On discussion with the patient, she admitted storing collected blood from her peripherally inserted central catheter (PIC) line in a plastic bottle that was found in her bedside cabinet, along with syringes. Another patient created anemia and apparent GI bleeding by using needles to venesect herself from the axilla and then ingested the blood via a straw. 74 If a patient withdraws blood from herself or himself after being injected with isotope-labeled red blood cells and then drinks the blood or injects it into the abdominal cavity, bleeding scans can be abnormal and may lead to inappropriate treatment. 75,76 Factitious cancer patients who feign cancer often enter a new institution seeking to continue treatment for their cancer and claim that they were referred by doctors in another city or state. They provide a convincing history, have scars compatible with previous surgical treatment for cancer, and often provide a false pathology report. They claim that their other medical records will be sent shortly. Alternatively, or in addition, some patients feign cancer and gain entrance into cancer support groups. One such patient participated in classes on death and dying. The class was so moved by her courage that it raised money for her to ride in a hot air balloon, one of her final wishes. 77 Several motivations apparently cause people to feign cancer. One is secondary material gain, malingering, perhaps to obtain narcotics. Another is an unconscious need to deceive the medical system and be subjected to diagnostic tests and therapeutic procedures. Some may seek the social status associated with the diagnosis of cancer, e.g., being lauded as a survivor, and take advantage of displays of sympathy and gifts from friends, co-workers, and others. 77 Some apparently feign cancer because someone they loved had cancer. One woman later stated that she was hoping to die as a result of immunosuppression. 78 Several of these motives may be present simultaneously. Whatever the motivation, the onset of feigned cancer seems to commonly occur after rejection by a loved one or after some other type of loss. Loneliness and isolation seem to be the precipitating factors in many people who feign cancer. Medical records would almost always be required before a patient is given chemotherapy for cancer or is subjected to cancer surgery. Patients who desire to feign cancer may steal and alter authentic records from other patients' medical charts and pass them off as their own. In one case, a patient scanned and modified records, making it even more difficult to recognize their fraudulence. 78 Gaining access to medical terminology, symptomatology, pathology reports, and diagnostic and treatment plans would be easiest for a hospital employee, probably explaining why the best and most complete forgeries are from people who work in hospitals. Despite oncologists' efforts to review medical records carefully, fabrications have been good enough in some cases to allow people with FD to obtain chemotherapy. 78 The diagnosis of factitious cancer is usually made by detection of inconsistencies in the medical history, evidence of fabrication of medical records, lies patients tell about their health insurance or personal histories, or fortuitous doubts about the patient's story raised by doctors. Claims of prolonged survival with a usually lethal cancer have helped reveal factitious cancer in some cases. Lessons from Case Reports. Table 23.2 lists brief summaries of selected case reports to further illustrate the wide variety of factitious diseases that can occur in the practice of gastroenterology. Table 23.2 Cases of Factitious Disorder, FD, in Gastroenterology. Presentation comments. Fistulizing Crohn disease with histology revealed only nonspecific abnormalities, and inflammation was more severe in the serosa than in the stomal. Bleeding 79 mucosa, suggesting extrinsic trauma. The disease was caused by self-inflicted wounds using a needle inserted through the vagina, rectum, and stoma. Refractory celiac disease 80. The patient had celiac disease that initially responded to a gluten-free diet. She later developed severe diarrhea, believed to be due to refractory celiac disease. The diagnosis was established by fecal analysis, which revealed that the diarrhea was caused by ingestion of milk of magnesia. Had the correct diagnosis of FD not been established, the patient would have received immunosuppressive therapy. Porphyria 81. A patient with abdominal pain and red urine. Freshly passed urine was red, but in porphyria, freshly passed urine is normal in color and turns red or brown when exposed to daylight. A room search revealed a drug containing ribosonic acid, a red-in acid solution. Death from liver failure 82. Nosebleeds, anemia, alopecia, hepatomegaly, and elevated liver biochemical test levels in a 29-year-old woman. A liver biopsy done about 18 mo before her death revealed changes suggestive of hypervitaminosis A, including fat-laden stellate cells. Although her serum vitamin A level was high, she denied excess intake of vitamin A. Just before death, she admitted that she had surreptitiously ingested grossly excessive amounts of cod liver oil. Intestinal Pseudo-Obstruction 83. An 18-year-old man had GI and urinary findings that led to a diagnosis of intestinal pseudo-obstruction. He became bedridden and required TPN and repeated daily bladder catheterizations, but physiologic testing revealed no evidence of a GI or bladder motility disorder. The patient's mother was suspected of Munchausen syndrome by proxy. The patient's stool and urine tested positive for emetine, a component of ipecac. The patient was completely well after 1 week of court-ordered separation from his mother. The final diagnosis was Munchausen syndrome by proxy. A double deception leading this patient developed episodic paralysis associated with hypokalemia and metabolic alkalosis. Plasma concentrations to the diagnosis of Bartter of renin and aldosterone were high, and a renal biopsy specimen revealed hyperplasia of the juxtaglomerular syndrome 84,85 apparatus, yielding a diagnosis of Bartter syndrome. 84 Subsequently, it was discovered that the patient was surreptitiously ingesting phenolphthalein but had been hiding the fact that she had diarrhea. 85 Recurrent wound infection in 5 weeks after liver donation, a post-surgical wound infection with septic shock. Developed. The donor's hospital. A woman who had recently bill was huge and was sent to the recipient's insurance, thereby threatening the recipient's lifetime benefits. FD donated part of her liver for was suspected because antibiotic-sensitive polymicrobial bacteria were cultured. Past medical records revealed transplantation. 86 Evidence of previous FD. Induced vomiting. To create a 25-year-old woman with hypertension used self-induced vomiting to increase her blood pressure by eliminating the treatment-resistant effect of her antihypertensive medication. Her motive was to achieve a prolonged hospitalization in order to avoid a hypertension. 87 Stressful home environment. Fatal non-thrombotic pulmonary. A 32-year-old woman was on TPN following complications of a Roux-en-Y gastric bypass and pancreatic autoislet embolization. 88 Cell transplantation. She presented with recurrent episodes of bacteremia with atypical pathogens. Sudden cardiac arrest with right-sided heart failure resulted in her death. The cause of death at autopsy was attributed to complications from pulmonary microcrystalline cellulose emboli, which likely resulted from self-injection of oral medication through a central line. Recurrent pancytopenia in a 50-year-old woman with a history of fistulizing Crohn disease was previously treated with 6-mercaptopurine, 6-MP, but woman with Crohn's disease 89 was told to stop the medication due to drug-induced pancreatitis. 2 months later she presented with recurrent pancytopenia. Results of a repeat bone marrow biopsy were non-diagnostic. Thiopurine metabolite testing showed that 6-MP was present with levels that predisposed to toxicity even though 6-MP had been discontinued several months earlier. The patient denied refilling the old prescription and taking the 6-MP, but her community pharmacist confirmed that a refill of 6-MP had been dispensed recently. Pancytopenia was attributed to surreptitious ingestion of 6-MP. Case 4: a 31-year-old man with abdominal pain. This patient was admitted to our hospital because of severe abdominal pain during the previous 6 weeks. 33 The pain was mid-abdominal in location and was present mainly after meals. He had lost about 12 pounds in weight. Physical examination revealed no signs of peritonitis. The results of EGD, colonoscopy, CT, US, and ERCP were normal except for a small benign gastric ulcer. His pain did not respond to potent anti-ulcer medications, so the ulcer was not believed to be the cause of his pain. A psychiatrist examined the patient and noted major depression with melancholia, recurrent type, with somatization, and an amphetamine was prescribed. The medication seemed to help initially, and the patient was feeling better the next day. However, on the following day, he was again having severe abdominal pain after meals. His abdomen was soft and without tenderness, and bowel sounds were normal. Demerol was given. Progress notes stated, pattern of complaints and his response to antidepressant are indicative of psychogenic pain problem coupled with dependent/oppositional personality disorder, and patient continues to be quite regressed. He makes the most secondary gain of each and every somatic concern. On the 10th day of hospitalization, the patient was lying in the fetal position with constant severe abdominal pain. Periumbilical tenderness was present, but there was no rebound tenderness. A progress note said, his mom and friends hovering over him. He does seem depressed, but the pain syndrome seems psychogenic in origin, not a depressive equivalent, and secondary to his dependent narcissistic personality structure. 2 days later a feeding tube was placed, and the patient was transferred to a psychiatry unit, where later he was found unresponsive. An abdominal film showed air under the diagram. The patient died a short time later. An autopsy revealed that patient's superior mesenteric artery was completely occluded by atherosclerosis, which led to necrosis and perforation of his small intestine. 33 Pitfalls in the diagnosis and management of abnormal illness behavior. In case 4, no organic cause was found to explain his severe abdominal pain and weight loss. This led a gastroenterologist to suspect a psychiatric explanation for the patient's symptoms, and a psychiatrist was consulted. After taking a psychiatric history and observing the patient, the psychiatrist made a diagnosis of psychogenic pain, a term that implies that pain is caused primarily and maintained by emotional distress. This diagnosis was fully accepted by the gastroenterologist, and the patient was transferred to a psychiatric unit of the hospital. The thought processes were erroneous for 2 reasons. First, physical or organic disease cannot be excluded with certainty, and failure to discover an organic disease to explain severe abdominal pain did not constitute evidence for a psychiatric etiology in this case. Moreover, there were no clues suggesting positive evidence for abnormal illness behavior. Although consulting a psychiatrist to help manage any associated depression may have been wise, the gastroenterologist should have known that a psychiatrist cannot accurately diagnose emotional distress as the primary cause of severe abdominal pain by performing a psychiatric evaluation. Second, the psychiatrist should have known that secondary gain is part of normal illness behavior, and he should have recognized that there was no supporting evidence for abnormal illness behavior. He should not have made a diagnosis of psychogenic pain, which closed the door to a further search for a medical cause of this patient's severe abdominal pain, which was classic abdominal angina. 90 In this regard, the advice of Nadelson rings true. The psychiatrist must encourage the referring physician to confront the patient on the basis of clinical evidence, recognizing that the psychiatrist's own diagnostic acumen may fall short of divining the hidden truth. 91 According to our interpretation of this advice, a diagnosis of abnormal illness behavior as the primary cause of physical symptoms should be based on clinical evidence, such as that discussed in boxes 23.1 and 23.2, rather than on information gained from a psychiatric evaluation. In this case, the negative clinical evidence could have been compiled by either the gastroenterologist or the psychiatrist. Unfortunately, no one did it. Acknowledgement. The authors thank Mark D. Feldman, MD, from the Departments of Psychiatry and Psychology at the University of Alabama, Tuscaloosa, Alabama for his many contributions to this chapter in the 10th edition. Full references for this chapter can be found on vexpertconsult.com.